What do you want to do?
Okay. So sorry, kind of skipped like a little bit of the introduction, but we're gonna, as you can tell, we're gonna talk a little bit about pediatric, endocrine, and it's gonna be like a potpourri type thing. So it's gonna be a little bit of everything. And we are going to mix it with some Kahoot questions as well. Just keep in mind, we do have prizes for the first, second, and third place winners. So try to pay attention and try to do the best that you can. Great, so we went through our first question. We're going to do one more question, and then we'll do a little bit of slides to get you guys into it. All right. Wow, looks like the vaccine can make you smarter too. All right, one more question. Let me know if you guys want me to read it too. So a mother presents with her 1-week-old infant who was born at home. She's concerned that the baby's lethargic, has been vomiting for the past 3 days. Also notes that the baby's eating poorly, continues to have good urine. It's a hard picture to see. But what the following study should be obtained next? Okay. Great. So let's. Are you guys okay with the double screen, or do you want me to put this in like presenter mode and go back and forth?
Yeah, maybe that would be better.
Go back. Okay.
Good, and they can see it on Zoom.
And Zoom should be able to see it too.
They see it, yeah.
All right, so let's talk a little bit about congenital adrenal hyperplasia. So you guys did pretty well in the questions. So CAH, it's autosomal recessive disorder, and the problem is the defect in creating steroids. So as we know, that affects the adrenal glands, as we can see. The adrenals, they sit on top of the kidneys, and they're responsible for producing 3 different hormones. So you have your corticosteroids, your mineral corticoids, and your androgens. So different parts of the adrenal, you have your adrenal medulla and you have your cortex. Within the cortex, you have 3 different zones. You have your zona reticularis, your zona fasciculata, and your zona glomerulosa. So the production of cortisol, which is the issue with CAH, is found in the zona fasciculata, and that's part of the adrenal cortex. Usually, it has 5 different enzymes that are responsible for creating this cortisol. So when you have CAH, you have a deficiency in any one of these 5 different enzymes, and because of that, now you're going to start getting chronic levels and elevated levels of ACTH, right? Because this is the whole negative feedback system. We're not going to go through all those nitty-gritty details because you guys probably remember them if you've made it this far and passed all your steps. But because of this negative feedback, you start getting this overstimulation of the adrenal cortex. Therefore, you get the hyperplasia. And that's why it's the congenital adrenal hyperplasia. So you get this impaired enzyme function, as we talked about. And remember, when you have a defect in one of the enzymes, you start getting elevated precursors and elevated in the different steps that it goes. So the most common enzyme that we have for the pediatric CAH, which accounts for about 90% of this disease, is the 21-hydroxylase deficiency. So know that when you have a deficiency in one, we talked about how you get elevated precursors because of this deficiency. So because of this, now we're going to have an increase in your 17-alpha, which puts you at the 17 hydroxylase progesterone. So that's been the question that we just previously had. So what level would you test for? You're not going to test for the deficiency. You're going to test with what is actually getting elevated. And that's your 17-OH progesterone. There are also other forms of CAH, not only just the 21-hydroxylase, and that's your 11-beta and your 17-alpha. Okay, so individuals with CAH, they start getting, because of this adrenomegaly, they have an excessive amount of androgens. These androgens are going to give you that normal sexual development, especially in females. So this was your first question, which many of you did well. So what you think could be a small penis and testes is actually enlarged clitoris and fused labia. So this gives you your ambiguous genitalia. So classically, females with the 21 hydroxylase deficiency, although they're genetically female, they're going to get this masculinization and the virilization, but they have normal internal reproductive organs. So it's just the external, and it usually picks up right at birth. So we talked about how you can have the other enzymes that are not quite common, but they still present with different types of phenotypes and different types of identifying factors. So your 11 beta hydroxylase. So they're usually protected from any sort of adrenal crises, and these are not the patients that are going to go into shock, but these are the patients that could potentially have hypertension and salt retention. They do present an ambiguous genitalia in females as well. And then your 17 alpha hydroxylase. So this deficiency usually results in ambiguous external genitalia in males, not so much in females. But with females, as they present later in life, they start getting like pubertal development issues and amenorrhea, and they're having issues with fertility. So then you have your major 21 hydroxylase deficiency. It's split up into your non-classic versus your classic. So your non-classic usually is the milder form, that's what they say. They present later in childhood, usually by adolescent. Most of the time, it just includes like phenotypical features such as premature body hair or any acne development. In adolescents, it's usually just the excessive facial hair that's what gets them to come into endocrine in the first place. And some of the time, they can actually present with sub-infertility as well. Then your classic one, this is 75% of your patients with 21 hydroxylase deficiency. And it's also, because you have this 21 hydroxylase deficiency, you're gonna have the deficiency in aldosterone. With this deficiency in aldosterone, you're gonna have the inability to retain salt. So you have something called salt wasting. With the salt wasting comes all your fluids. So now you're gonna become hypotensive, you're gonna have dehydration, hypovolemia, low blood pressure, and then essentially leading to shock. So without treatment for the classic 21 hydroxylase deficiency, your kids can get very, very sick. All right, so let's go back to here. All right, so for our next question. All right, 7-day-old infant brought in by EMS after having seizure activity. Glucose in the field was 30. They gave her D10 via IV. She took ICTIL. She has an enlarged clitoris and labia fusion. Her labs are hyponatremia and potassium at 3.5. Which medications would you give next? All right, so good job, guys. So the treatment, while CAH can never be cured, it can be managed and treated effectively. The primary goal of what you're trying to do is to reduce these excess androgens, right? Because excess androgens are what's causing the problems. So you want to reduce those androgens, and that's like your main goal for it. So in terms of daily medications, these kids can go on glucocorticoids to help replace your cortisol, mineral corticoids to help replace the aldosterone to prevent them from going into shock. And sometimes they're just going to need some salt supplements as well. Keep in mind that
the salt that does your shock.
I think that was a chat.
Yeah, it was.
Jen, what did you say?
Sorry, I didn't realize I was not muted. Go ahead. Sorry.
So just keep in mind any form of stress, including illness, when they come in. This is when they're coming into the ED, right? This is when they're getting their viral illness, post-surgery, any form of stress the body intakes. That's when you're going to have an increased need of hormones. So in terms of surgery can be considered to correct the appearance of your ambiguous genitalia, as well as to relieve any urethral or vaginal outlet obstruction, especially if it's causing infection. Surgery is ideally done at 6 months to 12 months of age. But it can be done later. So it's always a joint decision-making process. There are many families who decide that, as my child gets older, I want them to figure out what they really relate to. Do they feel like they're more a boy or more male or more female? And if that's the case, then they can perform surgery based on what the child wants later in life. But of course, it has to be a joint decision-making, and it requires a lot of different multidisciplinary approaches. And then your non-classical type, which we talked about, is a little bit more of the milder form. So these patients don't really have obvious signs of CAH, so they don't necessarily require medical or surgical treatments. A lot of times, as they grow later in life in adolescence, if they have excess body hair or excess acne or things that may affect them in just how they are treated in life and how their appearance is, they can be treated with some glucocorticoids to help cortisol. Most of the time, they may just need a taper of it if they're definitely not on any sort of daily medication, do not require any surgical intervention. Okay, so some treatment considerations of these children with the classical CAH that end up in Shah. So one of their main things is that they're hyponatremic, right? They all have these electrolyte abnormalities. So usually normal saline will do the trick. They may need some oral mineral corticoids to help kind of push them over to help with the appropriate sodium levels. They're also hypoglycemic. So just keep in mind that when you're giving them the fluids and normal saline, now you're also dropping their glucose a little further. So after the first bolus, it's important to include dextrose and any of the remaining fluids that they may have. They are hyperkalemic, so always get that EKG. It's pretty rare that it's going to cause any cardiac manifestations from it, but you have to rule that out, especially in the ED. And if it does have any known issues with peak T waves or any hyperkalemic side effects, be sure to have calcium gluconate on board to protect the cardiac function. And then give cortisol. That's the only thing that's really going to help them, especially when they're coming in with a time of stress into the ED. That's the only time you guys are really going to see them as ED physicians. So hydrocortisone all the way, you have to have it in hand, and that's the first thing you should acknowledge and recognize as they come into your ED, almost going into shock. So hydrocortisone, 50 to 100 mg per meter squared, or you could do the IV hydrocortisone 1 to 2 mg per kg as the initial dose. There are some alternatives. You can use methylpred, dexamethasone, or fludrocortisone. They don't work as efficiently, but if you cannot get the hydrocortisone and you need to give something, this is something that you can consider too. All right. Yep.
I was going to say, I know they test for the deficiency, the most common one on the newborn screen.
Yeah.
But if they were born prematurely and required steroids, then the newborn screen can be falsely normal.
100%. Yes.
Yeah. And then I don't know if you said the younger they are, the more likely they are to have hypoglycemia. So you very well have someone with hyperkalemia and hyponatremia without the hypoglycemia. It can still be congenital, an adrenal crisis.
Yes.
Yeah, and then anytime, obviously this is super rare, but anytime you have any kid coming in who's not responsive to antibiotics, fluid, and vasopressors, you should definitely think about whether you're missing something, and you should give hydrocortisone, because shock is obviously way more common, but adrenal crisis is definitely something.
Yes. 100%. Great point. All right. Your next.
Yeah, so I just wanted to clarify since anyway, that is the way it sort of sounded as far as the, can you hear me?
Sorry, give us 1 second, Dr. Chow. Just let this question go, and then we can hear you. I think it's overlapped.
Yeah, just let her know.
Okay, I'm coming in. It's okay. I'll come in
She said
give
she's
my 2 cents.
Okay, great. Sorry, Dr. Chow, did you want to make a... We can hear you now. I'm just perfect. Okay. All right, great. And one more question. Okay, 5-year-old female, his response from a state laboratory with a TSH level higher than 200. The neonate was born uncomplicated, vaginal at 40 weeks. Mother took levothyroxine for Hashimoto's thyroiditis and elevated TSH. So what's the most likely cause of these neonates with these elevated TSHs? Okay, so congenital hypothyroidism, seen in 1 in 1,500 to about 1 in 2,000 newborns in the United States. Higher in Hispanics and Asians. It's one of the most common preventable causes of mental retardation. That's why it's so important to identify and so important to know about. Majority of the cases, it's going to be congenital. So these are your aplasia or dysplasia of the thyroid gland itself. This counts for about 85% of the cases. It can be acquired. If it's going to be acquired, the most common cause is going to be Hashimoto's thyroiditis, especially in the mom. So it can be acquired that way, but more than anything, it's the dysgenesis itself of the thyroid gland. So the clinical features of congenital hypothyroidism are so subtle, especially in the beginning. Most of them end up being undiagnosed at birth, and that's why we talk about the newborn screen, and we're going to talk a little bit more about it as well. It's something that you definitely don't want to miss because this is the most, like we said, the most preventative cause of mental retardation. The subtleness of it, and especially in the first 2 weeks, usually comes from the maternal passage of the thyroid hormones through the placenta. So it kind of gives them a little bit of a bump, especially after birth, to deal with this hypothyroidism. And many of the times too, the actual thyroid gland is still functioning, although not quite up to par. It still has a subtle functioning feature of it. So you may not get these features at birth. This is definitely not something that you may be able to pick up in the newborn nursery, but this may be something that within the first couple of weeks that they come into your ED, this is something you have to start thinking about. So in terms of infants, like I said, we have these vague symptoms as every infant has for every disease. So you get delayed growth, developmental delays, poor feeding. Some of the main signs and clear things to look for are constipation, a large fontanelle, prolonged jaundice, and an umbilical hernia. So as you can see in that patient that we had in the picture, it was kind of a little bit of all of that, but very subtly. MYXEDEMA coma. So you guys will see it in the adults, and you probably know a little bit more about it, but it is rare in children, but super, super lethal. The mortality cases are about 30 to 60%. It's usually caused by primary hypothyroidism, which is greater than 95% of the cases. 5% can come from pituitary cases as well. Usually seen with severe hypothyroidism. The pathophysiology of it, so you get a decrease in T3, put you in a hypothermic state, which ends up having organ dysfunction. Then you get decreased cardiac activity and decreased brain function. The presentation is very similar to like a very decompensated hypothyroidism as well as shock. So you get your hypotension, you have your bradycardia, your hypoventilation, also puts you in respiratory acidosis. Your hypothermia, this is any temperature lower than 95.9. And just keep in mind, the lower the temperature, the worse the prognosis is going to be for the patient. They're hypoglycemic, obviously they're altered, and then eventually leading to death. Some physical findings that you'll find, especially in infants, you get this generalized puffiness of the face, macroglossia, and ptosis. This is something that it's coinciding with hypothyroidism, so you get that large tongue and that overall puffiness. But as they look sicker and sicker and decompensating, this is something to think about. Some causes of it, infection, the most common trigger, especially for infants, is going to be pneumonia and sepsis, of course. Trauma can do it as well, any cold exposure or any form of anesthesia that they were associated with or affected with. Yeah,
Sure. So I had a 12-day-old the other day. I haven't followed up yet, but baby came in with poor feeding and kind of a weak cry. Mom didn't really have good prenatal history, so we looked up the newborn screen and it still wasn't back at 12 days. And so you do have to keep, getting thyroid function tests as part of your workup when you're taking care of these babies. Baby did not have typical faces, but definitely was kind of weak and not feeding well, and had been a prolonged history. Like all 12 days, they've been like, went to pediatrician, we did this, but just to kind of keep it up back of your mind.
How long do the screens normally take?
2 weeks.
Yeah, they
Oh,
take
really?
2 weeks, and now
Okay.
with it being online, it should be faster and easier, but we could not find the system. We
Okay.
tried like 50 ways to choose it to try it. And we couldn't.
Okay.
We'll talk a little bit more about it, but it is pretty tough. It's not as easy as it should be to just get answers from a newborn screen. Okay, so let's do another quiz question. Okay. So a 12-year-old with septo-optic dysplasia, ED for lethargy, nonverbal, non-ambulatory at baseline. He's unresponsive to painful stimuli, weak peripheral pulses, starts IV, informs you the family stopped using one of his chronic medications. Sorry, guys. All right. Okay, so in terms of treatment, so like we mentioned, the hypothyroidism, the symptoms are so subtle, like Dr. Khan mentioned, like it can come in so vague, you don't really know what it is. And like we said, it's possibly due to some like still like residual tissue functioning of the thyroid, as well as some internal placental transport of the thyroid hormone. But like we said, they can get sick really quickly, as well as the longer you wait, the worse their mental capacity is going to be. So because of this, we do the newborn screen, like we all discussed. It is a New York State mandate. The newborn screen usually occurs, it has to occur prior to discharge. So it depends if they're a regular baby in the newborn nursery. They usually do it within the 24 to 48 hours prior to discharge, but a lot of times they do get discharged within a 24-hour period. So as long as it's done prior to discharge, that is the New York State mandate, which is not always great. In NICU babies, they usually do it at day 7 of life. So as you can see, they get these dried blood samples and they just fill in the holes, and then they send it off laboratory tests for a bunch of different enzymes and different diagnoses and different diseases. So with congenital hypothyroidism, you can see it as a primary screen with the elevated TSH. Any TSH greater than 25 is considered abnormal. And like we said, it takes about 2 weeks to come back. So it is a little bit of an ordeal. It's not like, it's usually just the pediatricians that have the login. It's not necessarily either like PEM people are gonna have this login either. So it's a little difficult for us to follow up. Ideally, we do rely on the pediatricians a lot to make note of it, saying the newborn screen's not normal or it's pending or whatever the situation is. But if a patient does come into your ED within those first 2 weeks of life, it's really important to consider it and to make note of it if the newborn screen is back and if it's in their chart. Or maybe you may have to take that extra step to call the pediatrician to see. So say you are in the ED and you do get an abnormal TSH level, the first thing that you're going to do is repeat it. You're going to repeat your T4, you're going to repeat your TSH, and then you're going to send off a repeat newborn screening as well. So all 3 things need to be repeated when an abnormal test comes back. The second thing to do is while you're waiting for the results, you can wait in the ED or they can go home, and if they want to follow up with primary care, whatever it is, you have to start them on treatment. You cannot wait for the repeat results to come in. As soon as the levels are drawn, you have to start them on treatment. It's super, super important. So a lot of the times, especially when the newborn screen is done within the first 3 days of life, it can actually create a false negative. So this is mainly because they're still having this surge of maternal hormones in them, so the TSH can be falsely elevated. But this is not something you want to miss. So most of the time, it is a false negative, but if it is abnormal, this is something every day that you miss can cause more and more detriment to your patient.
You can get the newborn screen cards from NICU.
Yeah.
Just call them and they'll shoot them down to you.
Yeah, and it's pretty simple to do. It's just a heel stick. Okay, so in terms of treatment, Like we said, it should be started promptly, and the whole goal of it is to become a euthyroid as early as possible. So your treatment of choice is going to be levothyroxine, 10 to 15 units per kilogram per day as your initial dose. There have been studies that shown that your IQ level and your age of diagnosis for congenital hypothyroidism have an inverse relationship. So just keep that in mind, that literally every day that you're waiting can actually be very detrimental to your patient. The goal of your therapy is to normalize your T4 within 2 weeks and your TSH within 1 month. So there's one study that where the T4 actually took longer than 2 weeks for it to normalize, and those patients had significantly lower cognition and mental capacity. So it really is time sensitive, and the idea is to get them at a therapeutic level where they can normalize within 2 weeks. So levothyroxine, it is the treatment of choice. Currently in the US, the only thing that's approved are tablet forms. You are able to crush them. You can mix them with breast milk. You can mix them with water, and you can create a suspension. So essentially, just give them into a syringe. Keep in mind that any interaction between calcium or iron or soy milk will cause the levothyroxine to be essentially not working. It's going to cause a problem with absorption. So patients on our soy milk formula, they cannot mix those two together. And then patients who are taking a multivitamin, including iron supplements, cannot take those two together as well. So something to keep in mind and to tell parents.
Even milk, just like
So
calcium.
So I think it's calcium supplements for it. So regular milk and breast milk, regular formula and breast milk should be fine. Okay. Let's go back to our foods.
Can I ask a question about that? Is that, so if, say you find somebody hypothyroid, like is this an admission diagnosis, or do you just write for levothyroxine?
So a 12-day-old who wasn't feeding well gets admitted. And, it'll be up to you what facility you're in and how comfortable you're feeling, whether you want to send a child home, depends on how they're looking and how they're feeling. It's not just based on, we have a low TSH, what should we do? We send it on the screen. They're very well appearing, but the PMD called you and said, we've lost a newborn screen, but we're sending the baby to the ED. That's the baby that if they've had any symptoms, you would repeat a newborn screen and do a TSH and T4 and in your facility and start them until they get the screen back.
More than likely, if they're coming to your ED, it's not coming because, oh, I need medication. It's more than likely like, hey, something's wrong. They're not feeding well, they're not growing, they're not feeding right. And then if anything, like, especially with our patient population, you should consider maybe just admissions for like social stuff too. Like, let's get endocrine on board. Let's get social work on board. Let's make sure you can get your medication. Let's make sure you know how to crush them and administer them. So it may just be better for like educational purposes to admit them. All right, so next question.
Wait, oh, you already did it? Okay. No. No, I want to see, Jen, what did you have? What were you trying to say before?
I just wanted to clarify that with the whole, just the way it was, or at least the way I perceived it, as far as the treatment for CAH, the steroids are really important. They're self-wasting. Really, you don't really care.
Yeah, you have to give hydrocortisone.
Yes.
That's life-saving.
All right, next question. All right, 8-month-old, decreased level of activity, infantile spasms, which she took pred for 2 weeks. She's sleepy but arousable. She has a brown face, excess adipose tissue, and then these labs. If you squint and come closer, I don't know. Great job. You still fixed it up. All right. Okay, adrenal insufficiency. So we have 3 causes. The first being primary, which means destruction to the actual adrenal gland itself. Secondaries, you're going to be your deficiency in ACTH secretion, and your tertiary, which is your deficiency in the hypothalamic pituitary secretion of CRH. So the most common in pediatrics is going to be your primary. CAH actually accounts for 70% of it, and the other remaining, the other 15% is actually an autoimmune known as Addison's disease. Addison's is rare in pediatrics, but potentially life-threatening. So this is something to consider and to consider when your patients are coming in, especially when they're sick. Usually results in bilateral adrenal cortex destruction. So then you get your decrease of the adrenal cortical hormones as well. So that's your cortisol, your aldosterone, and your androgens. So adrenal insufficiency, like we said, for primary, it's the actual insult to the adrenal glands itself. Can be caused by a couple of different things, including infection, usually sepsis, TB, CMV, or HIV. Other causes can be like your disseminated fungal infections, histoplasm, or syphilis. Keep in mind for your adolescents. Blastomycosis can be caused too, more common in South America, less common here. Adrenal hemorrhage is another main cause. Usually it's bilateral, like we said, precipitated by DIC or trauma. It can also be meningococcemia. So when meningococcemia actually infiltrates your adrenal gland, it's a syndrome known as Waterhouse-Friderichsen syndrome. I'm sure you guys all remember it for boards and then forgot it after. So something to keep in mind. So you should ask for signs of meningitis and look for a rash throughout the body as well. Infiltration of any sort, so hemochromatosis, amyloidosis, or metastatic issues can infiltrate the adrenal glands, causing issues. And then certain drugs can do it too. So ketoconazole can do it. It's prescribed pretty freely in the ED, as well as etomidate. So we know etomidate has always had this associated with adrenal crisis. It works by selectively inhibiting your 11 beta hydroxylase. So that puts you in like issues with your cortisol levels. There are many studies that show like the one dose that we give in the ED is actually not going to tip them over or do much of a difference, but always something to keep in mind when you're looking for your agents while you're in the ED. So secondary insufficiency causes usually due to exogenous steroid use, like our patient in the question. And then it can also be pituitary dependent loss of CTH secretion. So in terms of secondary versus primary, most of the time in secondary, your mineralocortical levels as well as your ACTH are normal compared to your actual primary insults. So your signs and symptoms. So you're going to have your decreased cortisol, like we discussed previously, even through ACTH. You're going to have your decreased aldosterone, and you're going to have your increase in renin. So when you have your problem with aldosterone, just keep in mind that you screw up your whole renin-angiotensin. Cycle. Can't think of the word. So you're going to end up messing all your electrolytes up as well. So in terms of your cortisol level, usually a low random level is seen. Just remember it's a diurnal pattern. So the cortisol level is going to be highest in the early morning and your first rise. So are you going to get your patients coming in their first rise? Probably not. So ideally, it's good to get a level, although it's probably not going to be your best. And one level is not going to really determine what this patient has. Something to keep in mind, if you do have a level over 18 for your cortisol, it's normal. So that's something that maybe then you can exclude. But ideally, it's not great. You should be getting levels throughout the day, especially one at your earliest in the morning. So we talked about the aldosterone system as well, and just keep in mind in secondary adrenal insufficiency, the aldosterone level is going to be normal. And then in your chemistry, like we said, it's going to mess up all of your labs as well. So you're going to get hyponatremia, hyperkalemia, and hypoglycemia. And then your ACTH cortisone stimulation test. So your ACTH stim test is what's going to be your diagnostic choice to determine where this insult is coming from. So what you basically do is you take a blood level of your cortisol, then you stimulate them with corticotropin, which is like a synthetic of their ACTH. Then you measure your cortisol levels after. If you have a high ACTH and with increased cortisol levels, you're going to have a primary insult. This means that your ACTH is just skyrocketing, but it's not producing enough cortisol in the end. And if you're going to have a low ACTH, that means no matter how much ACTH you're getting, you're not actually getting the stimulation from your CRH. So that's going to be more of a central issue. All right, let's go back to your Kahoot. All right, 16-year-old, one day of fever, stiff neck, headache, photophobia, had URI symptoms, pain with flexing, initiate management, CSF shows gram-negative coccyte, getting antibiotics, decompensating, so you have to do RSI. Which agent should be avoided? Great. Okay, so in terms of treatment, the whole point is immediate recognition because, like I said, anything in adrenal crisis can be fatal. It's a severe endocrine emergency, so you just need to know what to look for. So you already know that they're going to be hypovolemic. So fluid resuscitation, like any septic patient comes in, is extremely necessary. So fluid resuscitation, just with normal saline, but please make sure that you're adding your dextrose because just keep in mind that these patients are also hypoglycemic as well. So you want to correct your hormone deficiency, again, with like both the glucocorticoid and the mineral corticoid, but the most immediate treatment and the one that you really have to keep in mind, like Dr. Shah mentioned as well, is going to be your hydrocortisone. So you have to give your hydrocortisone dose as your initial dose. Those coming in with adrenal crisis, usually the dose is just 100 mg flat out to give, and then you can continue it every 6 hours or 24 hours. So it's any patient that comes in, any stress on the body. So if they're going to come into your ED, they're probably going to have some sort of stress anyway. So this is any viral illness, this is any fever, this is any gastro stuff, vomiting, diarrhea, whatever it is. They're in stress, you need to give them that dose of hydrocortisone to keep them from.
We don't see that many patients here, but we have seen a few the last couple of years.
Especially at downstate.
Even at county, parents come in knowing. They come in telling you this is what my child is on. They're giving you a hint at that moment. Save my child's life. First thing you need to order is a hydrocortisone.
All right, back to your Kahoot. Yeah. One more. All right, 2-year-old abdominal pain and vomiting, no fever, frequent urination associated with weight loss, lipid appetite, family history negative for diabetes. She's severely hydrated and has shallow breathing. Breathing is the most likely diagnosis. Okay, so DKA, we're gonna kind of run through this. You guys know about DKA, you see it all day, every day. Serious complication, insulin deficiency. We do see it. We know that it's more associated with type 1, but as we clearly know through clinical, we see it in type 2 all the time. As adipose tissue gets greater, they have insulin deficiency. Most of the body's fat is stored as triglycerides. When your liver disseminates your triglycerides, you get 3 fatty acids from it and a glycerol. So as your glycerol continues to produce more glucose, if you're not having insulin, you start getting into this ketotic state. So in terms of the physiology of it, you get this hyperglycemia, which leads to the hyperosmolality as well as osmotic diuresis. You get high levels of glucose, which also leads to the dehydration and your osmotic diuresis. Your ketones accumulate and you get this metabolic acidosis. Keep in mind for children, TKA actually happens in the greater amount in less than 5. And that's when usually they're coming into RED as like first timers. They were never diagnosed before, but they're coming in looking sick. They're having belly pain. They're having vomiting. So always keep in mind that we can't just attribute it to gastro every single time. It may be beneficial to maybe get that thing going on. It does happen in adolescents, but less than our like younger children. And these are mostly the adolescents that kind of know their history, know what's going on, and maybe they're non-compliance, or maybe they have some issues with medication, whatever it is. But it's mostly the children, and that's what like we need to focus more on catching these rather than just calling them gastro and sending them home. So in terms of our diagnosis for DKA, any hyperglycemia greater than 250, acidosis, so your pH is less than 7.3, your bicarb is less than 15, and your increase in ketones. So we either look at the A gap or we look at it in the urine. Okay, so testing, there are 3 ketones that we can use, the beta-hydroxyhydrbutyrate, which actually converts into acetoacetate and acetone. We do beta-hydroxy here, Southside as well as county side. It's pretty good because it usually measures severity up to it takes up about 75% of the ketones in DKA, so it's actually a good test to measure. It can be confirmed in the blood up to 24 hours before it converts into the acetoacetate and the acetone. So it's actually best when they're coming into the ED with those symptoms right away to actually get the beta-hydroxybutyrate versus the acetoacetone or the acetone itself. And then the serum ketone levels, whether we really look at it or not, sometimes it can be helpful. A normal less than 0.6, so that can maybe rule in or rule out. And anything greater than 3, it's a known DKA, and that's for immediate emergency treatment. All right, back to Cahoots.
I'm gonna, as far as something that I try and like individually talk to people about when it's working, but as Kosha mentioned, as far as catching these kids, because many times onsets come in a second, third time, and they'll be like, oh, that you have the vomiting and belly pain. So put into your history, you're asking, are they urinating more or less? Instead of, we all used to say about gastro, we all ask about less. But give them the option to say more. It would probably see, if it's just like in your just pattern of what you do, like the 2-second thing, like it's more important for the child.
Yeah, definitely agree with that.
And a finger stick should be actually, more often than not, has saved me in picking up somebody who's a new onset gastro, who doesn't have new onset diabetic.
Question, appropriate sequence of management for DKA. And a special thank you to Dr. Chow for this question. It came from her book. Okay, so in terms of treatment, your initial goal of management is to restore perfusion, right? So you're in a total body deficit of 7 to 10%. We usually calculate around 10% because we're assuming moderate dehydration for any patient that comes with DKA. So it's crucial for DKA therapy. The restoration of the intravascular depletion is like one of the major things that'll save you from DKA. Hydration also enhances renal glucose clearance, so you're bringing down your glucose levels anyway. And it actually augments insulin sensitivity. So all in all, fluids are the greatest cure for DKA, essentially. So hydration alone has been shown to actually reduce glucose concentration by 17 to 80% in some patients over a duration of 12 to 15 hours. That's why I would say as soon as they came in, we know that they're possibly in DKA. We start them on fluids right away. So we always do first phase as bolus and second phase as maintenance. But now in terms of fluids, what are we using? So this has always been a struggle between the adult side and the ped side, right? So you guys always come over and you put in your orders for LR. And then we sit there and we correct your orders for LR. And then our nurses go nuts. So what are we using? Are we using saline or LR? So it's still pretty controversial, and I really can't give you a definite answer, but I can give you some literature that may support one or the other. So the original concern based on LR was that it's going to potentially create more of an electrolyte imbalance, and then that could potentially lead to cerebral edema. And that was like the main thing in children why we wanted to avoid LR. But as you adult physicians always say, but if you're adding normal saline instead of LR, now you're adding to the acidosis by increasing your hypovolemic acidosis to it. So I don't know, what do we do? So there's a couple studies that came out. This one is one of the main ones that show that there is no difference. So there's no difference in length of stay. There's no difference to getting in terms of pediatrics. There's no difference in length of stay. There's no difference in which fluid is actually going to push them over into cerebral edema. So we can choose. It's easier for us to do NS in our ED. So we tend to just do NS and we can grab it easier. There's also no difference in time to normalization to pH between the two either, especially in pediatrics. So no difference in that. What about NS versus half NS? This is another struggle that pediatricians kind of go with, and depending on what institution you're in, they're going to give you some different answer for that too. So there's a PCARN trial that came out. That was a clinical trial for fluid infusion for rates, as well as which fluid types for peds patients in DKA. So again, no difference in anything. There was no difference in a faster rate to resolution for DKA, and there was no difference in neurological outcomes between the two types of fluids. So pick your pick. Always keep in mind your electrolyte abnormalities. You're going to get hyponatremia, hypokalemia, and hypophosphatemia as well. And then insulin. So insulin, obviously, we're going to give for all our DKA patients. In the ped side, we usually start at 0.05 to 0.1 per kg per hour. And then don't forget the dextrose, because the hyperglycemia will not kill you, but your hypoglycemia will kill you. So always keep in mind to get those finger sticks and get the dextrose. So, what do we do versus are we in downstate? Are we in Kings County? Are you in the Midwest? Are you down south? 2 bags versus 1 bag. This is another kind of hot topic in terms of pediatric DKA. So the 2 bag method actually means that you have 1 bag of D10 and NS and another bag of NS and the insulin. The idea behind it is that you can titrate it to prevent a quick drop of your finger sticks and your glucose level. So you want to minimize it, but you don't want to drop it too quickly, right? Because you said hypoglycemia can kill. So with the titration level, you can increase one, decrease the other, and kind of go back and forth and play with it. So ideally, in the past, it was supposed to be that this would give you the most accurate way of controlling DKA, and it'll help you bring down to a normalized level of your pH a lot quicker. It's actually proven to be wrong. Between the two, it does not change time to normalize your pH. So what do we prefer? So if you don't need your nurses to titrate anything, and if you can just get away with pharmacy making 1 bag for you, which includes your D10, your NS, and your insulin all in one, so why not do that? Be a little bit more efficient, right? So on the county side, we do the 1 bag method, and especially in the ED, we're trying to push towards that because our PICU prefers 1 bag method, versus the downstate side is still sticking with the 2 bag method. So you can try to argue with your nurses either which way. It's up to you. Good luck.
Good luck.
Just to clarify,
Yeah.
the way that it's written, it looks like your saline and insulin are the same bag. That's a third
It's the third one.
It's, okay.
It's the third one.
Yeah, sorry, I meant it more like, instead of titrating, you can kind of just have it like that. But yeah, that's true. All right.
And your fluids will always have your potassium supplement in it. That'll come from pharmacy. We don't have it in TV. That's only if they're staying long term. Hopefully they go upstairs before they need that.
Yeah. Okay, so your next good question. The diagnosis of new onset DKA before contacting your transport, giving 2 boluses of normal saline. Now in the ED, very difficult to arouse, he urinated on himself. Intact gag reflex, normally reactive pupils, but no constant gaze, and continued deep respiration. The glucose check was 5 minutes before arrival and it was 3:50, which should be done next. Essentially a deteriorating DKA. Okay, so cerebral edema. It's essentially what this patient had. It's a complication of DKA, and it's the most frequent serious complication of DKA in children. It's not really well understood as to why it happens. There are some theories and there are some risk factors. So some of the risk factors include like a younger age, new onset, prolonged symptoms. If your NA is not corrected, you have electrolyte abnormalities. You have a greater degree of acidosis, your pH is worse off than somebody else. And insulin in the first hour, fluid treatments can sometimes do it as well. So the question of whether like DKA, it's whether the treatment is causing this or whether it's a primary insult before the treatment even causes this. So a lot of the recent studies have shown that it could be from like a lack of adequate blood flow to the cerebrum even prior to treatment. So a lot of times it's just during the DKA before the treatment starts, you get this inadequate blood flow to the brain, which is actually can cause the cerebral edema before even this reperfusion theory. So we've kind of all been trained to do this reperfusion theory. That's why we're so cautious about our fluids and what fluids to be used. But there have been some studies that have shown that it's possible that it's happening even before our treatment is even initiated. So something to keep in mind. Presentation-wise, a lot of times they can be asymptomatic when they come in. Usually happens 4 to 12 hours after therapy initiation, if it is part of the reperfusion. And then sometimes it could just happen before treatment is initiated too. So it's not necessarily this like whole concept of treatment. It usually occurs in less than 1% of any pediatric DKA episodes, but if it does happen, it accounts for 60 to 90% of all DKA deaths. And then 10 to 25% of survivors will have some permanent neurological injuries. So keep in mind that you need to really, really check on your DKA patients. And as soon as they start deteriorating, this is fine. Okay, so some warning signs and symptoms. It's differentiated between the major and the minor criteria. Your major criteria is obviously any altered mental status or any fluctuations in your conscious levels. Heart rate deceleration, and that's not due to sleep or fluid resuscitation. So that's something to keep in mind too. If they're comfortable and they're not anxious and they're sleeping and you notice that the heart rate is coming down or maybe coming down a little too quickly, that can be one of the major signs of cerebral edema as well, and especially incontinence. Minor criteria: vomiting, headache, lethargy, a diastolic blood pressure greater than 90, and then age less than 5. It's a little bit hard to determine what they're thinking and how they're decompensating. So in terms of treatment, treat right away as soon as you suspect cerebral edema. It includes reducing your rate of IV fluids by 30%, elevating the head by 30 degrees at an angle, initiation of mannitol right away, and that's a dose of 0.25 to 1 grams per kilograms over 20 minutes. You can repeat the dose of mannitol if you feel like there's no response of 30 minutes into 2 hours. You can do another dose of mannitol, as well as 3% sodium chloride, and that's usually 5 to 10 ml per kg over 30 minutes. And then if you need to intubate, you want to avoid hyperventilation. So that's something to keep in mind as well. So as soon as you suspect cerebral edema, start and initiate your treatment right away. All right, back to Kahoot. Okay, so this was vitamin K deficiency. So usually in the newborn period, newborns will always receive a single dose of vitamin K immediately after birth to prevent bleeding, right? Everyone remembers this whole coagulation cascade. So the deficiency can present 2 to 14 days after birth. A lot of the risk factors include parental refusal of vitamin K injection, breastfed newborns, because there is a less amount of vitamin K in breast milk versus formula, as well as any malabsorption that happens in the newborn period as well. Something else to keep in mind in terms of RED is if they are born extramural and they're born at home, and sometimes they may not come into RED right away, and they may just decide to stay at home. A lot of families do not come in to actually seek help after if the baby is doing fine after birth. So it can be a couple of days after presentation, just find that baby was born at home, they never received that vitamin K injection, and they can be the ones with intracranial bleeding. Usually in terms of presentation, the first signs can be oozing from the umbilicus as they're born. They can have gingival bleeding as well as some epistaxis. And then the later stages are going to be intracranial hemorrhage. All right, back to the Kahoot. Should be done. 12-year-old immigrant from Somalia, worsened vision at night, poor nutrition, dry, flaky skin, fingernails are broken, and this is the eye exam. Great. Okay, what is vitamin A deficiency? Vitamin A, fat-soluble micronutrient, usually in the regulation of visual acuity, epithelial tissue integrity, immune response, and gene expression. That's how you get kind of the systems. Deficiency is usually found in the malnourished, elderly, or the chronically sick in the United States. But otherwise, in like resource-limited settings, it's usually like a malnutrition issue. And that's why it's the leading cause of preventative blindness in the world. Your signs and symptoms, you're going to get the big top spots. So they're abnormal squamous cell peripheralization and keratinization of the conjunctiva, usually seen with younger children. The blindness is usually due to the retinal injury. They get this poor adaptation to darkness as well. Dry skin, dry hair, broken fingernails. They get follicular hyperkeratosis. It's usually secondary to the blockage of your hair follicles, and then they get these positive keratin material in them. So it just gets like a hyperperipheralization of your epithelial. Let's see. So in terms of treatment, just consumption of vitamin A-rich foods. In the U.S., it's usually due to like this chronically ill patients, like cystic fibrosis. They have some sort of like malabsorption. So treating the underlying issue and then supplementing them may be the way to fix that. All right, Kahoot. Four-month-old, lethargy, drowsiness, and acting like themselves. The pediatrician was concerned with how much formula was taking. They're originally taking 2 ounces and then told her to do 4 ounces. So mom added more water with the 1 scoop of water to get 4 ounces. Since then, not really responsive, decreased reflexes. What electrolyte abnormality? Great. Okay, hyponatremia. So after febrile seizures, this is the most common cause of first-time seizures in children, usually younger than 2. Can be caused by some GI disturbances, but more than likely, especially when they're super young, it's usually improper formula mixing and can be in water intoxication. Some of your symptoms, lethargy, decreased reflexes, and decreased respiratory drive and seizures are going to be your late findings. So again, they come in with these vague symptoms of not really feeding well, or just kind of like just not really reactive. And then if you look a little bit more into their history, you notice that this can actually be a hyponatremic issue. In terms of treatment, you can give us a 3% sodium chloride at 5 to 12 ml per kg. The goal of the sodium is to keep them at 125, so you don't want to correct too rapidly. And then just always ask about formula mixing. You know, we come in just assuming that everything is GI related, but it's important to know that if they're formula based, which is a lot of our patient population, how they're actually mixing it. Because this can be a very serious cause, and it can just be super innocent from the mom, like not really understanding what's going on. All right, back to Kahoot. All right, 6-month-old with seizure, acting like himself, but a little bit jittery. Mom strictly uses a nut-based formula because he's a strict vegan. Performed for broccoli glucose, which is 82. Vitals are fine. Generalized tonic-tonic movements of all 4 extremities. Physical exams otherwise normal. While you're waiting for results, what medication are you preparing to deliver based on these? Sorry. All right. Okay, so the seizures were caused by hypocalcemia for that one. Usually associated with some neuromuscular excitability and lead to muscle contraction, which is also known as tetany. Fingers can be bent and they can be like backed in the same position, kind of like a spasm. So some signs and symptoms that you guys know and have used before, these classic signs, the Trousseau signs. So if you twitch the ipsilateral corner of the mouth, they should have this like twitching spasm movement, as you can see in the picture, as well as if you use the blood pressure cuff for the ipsilateral hand, they go into this like spasm muscle contraction. So just keep in mind that these seizures are different from any sort of infantile seizures or any sort of metabolic derangement because they're resistant to any anticonvulsants. So something to keep in mind when these patients come in and you're trying to give them push Ativan and it's actually not breaking. Some of these labs will actually show hypoglycemia, and that's one of the major causes of seizures as well. They're usually brief and frequent too, and they're not going to have much of a post-ictal stage. So it's not going to be this prolonged stage and then they sleep for hours on end. They kind of jitter and they do their spasms and their muscle contractions, and then they break and they do it again and they break, and it just keeps happening over and over again. So that's a little bit different than your typical seizure activity. So it can happen with these vegan, like strict vegans, but there are ways around it. Just because they're vegan doesn't mean that they have to keep their beliefs to provide for their child. So there are vegan-friendly diets, especially for infants. You can do a soy-based formula, but soy-based formulas are the only options for vegans. So if they cannot tolerate the soy-based formula, then you have to have a serious talk with mom about what she truly believes in and what we can do. All other sorts of formula are an animal derivative. So this is the only based formula that's acceptable for vegans. There are not acceptable alternatives when they want to do things at home. So we have to keep in mind that no matter how adamant mom is, a home prepared soy milk formula is not acceptable. Rice milk, not acceptable. Non-dairy creamers, which is actually used more often than you think, not acceptable. Water-based cereals or fruit, vegetable juices, a lot of moms will think like juice for them prior to 1 year of age, and no, not acceptable. So back to the Kahoot. Last question. All right, 3-year-old traumatic arteriosis, cleft palate, hearing loss, developmental delays, history of recurrent upper respiratory infections. What are they most likely to present with? They also have ocular hyperterealism, overfull helixes, cognitive nasal. Is that Rosie? All right, we have prizes for our first and second place and third place winners.
It's kind of cheating.
I know, it is a little bit cheating.
Cheating if I got all the
I guess you're a ringer, you know, you're kind of like a ringer.
I mean, I think it should have been more for the EM people, but okay.
Yeah, give us a number 4.
Yeah, I'll leave it with number 4, we'll check it. All right, so this patient had DeGeorge's syndrome. So the most common phenotype comes from the abnormal development of your third and fourth pharyngeal pouches. And these are the structures that form your thymus and your parathyroid glands. Because the third and the fourth pharyngeal pouches are affected, it also affects the development of your first and second pharyngeal pouches. These are your maxillary and your mandible formations. And that's why you get this kind of slew of presentation is all kind of all over the place. It's the most common genetic cause of hypoglycemia, and these are the microdeletions of chromosome 22q11. The presentation, also known as catch-22, if you guys remember this from your boards, you get cardiac involvement, you get abnormal facies, including like that mandibular and maxillo issues, so that's where you get your cleft palates, sorry, there for C. Your thymic aplasia, that's where you get your immune deficiencies, and so they get these recurrent upper respiratory infections or recurrent infections in general. And then your hypoglycemia and your hypoparathyroidism. So like we talked about a little bit for hypocalcemia, it can cause any event during stress-related issues. It can cause these seizure-like activities or these spasms. Okay, I think we went through a lot. If anyone has any particular questions. Otherwise, I say we enjoy our holiday.
I had a 2-3-day-old who had just been discharged in the morning and had come in in the evening with seizures. And when we did the blood work, we found that the calcium was like almost nothing. And then if you did a chest when we did a chest X-ray, you couldn't see a thymic shadow. It's very easy to pick up if you just kind of keep it in the back of your mind.
Good job.
Nice.